Okay, so this is the Week 8 lecture, and I'm Anne Taylor. I've come to talk to you about health systems. So last week Kate was talking to you about the social model of health and health determinants and inequality, which we'll have a quick look at again in a minute. Today I'm going to talk to you about the health system. Could you just pull the door to, because it's awfully noisy, thanks. So why do you have to have a sociologist come and tell you about the health system? You're all citizens, well, most of you I think are probably citizens of Australia or permanent residents of Australia. You're probably familiar with the health system to a greater or lesser extent. But the point of doing sociology is to step back a bit and think about things as a whole system rather than your own particular knowledge of it. So my role in the university is that I teach health sociology largely to health practitioners, mostly midwives, which is my own area of research interest, and I also teach the big nursing course who also do social determinants like this. So I would assume that if you want to belong to a an allied health profession, you might have a mixture of motives for doing that. Your motive might be to help people. It's a noble motive. The other reason would be that health profession jobs are, by and large, well paid, intrinsically interesting and valuable, give you a sense of meaning in your life, and also they're usually socially quite well regarded. So you've probably got a mixture of motives and reasons why you're training and doing the degree that you're doing. So at the moment you're probably focused on getting clinical skills and getting qualified, but as you go through your career, you'll be faced with decisions about where to work. You might belong to a professional association. There might be policy changes or regulation changes that your professional association might want to participate in. So it's important to get an understanding of debates around how not only just the health system we've got, though this one is actually quite complicated, but also the different directions that the health system might proceed in, and also how that relates to the values of Australia and the health of the population, which was what we were talking about last week. So we've got a range of images up here which shows you that healthcare system and health professions are multiple and complex, ranging from health promotion, exercise, nutrition, education, face-to-face care, and the running of big institutions like acute care hospitals. So today we're going to look quickly, we'll review learnings from week 7. Then I'm going to talk about the healthcare system, which, as I said, in Australia is we've got a very interesting mix of public and private, which can be quite complicated to explain. And we'll finish by looking at how Australia's health system compares to other kind of health systems at the extremes of the public and the private. And then I'm going to talk to you about health professions. Now this is a particular interest of mine because my PhD was about changes in the midwifery profession. So I'm particularly interested in the ways that different health occupations function in the health system and and their relative power and autonomy. So I hope that you'll find that interesting, because we'll look at why do particular groups have power in the health system, their knowledge, expertise, and the kind of evidence they use, a little bit about professionalisation, the role of medicine, allied health, complementary and alternative medicine. There's a big sociology literature on that. And then we'll look a little bit, and this is something that Kate, particularly close to Kate's area of concern, which is the role of peer workers. So we'll talk a lot about people who've got high levels of education, and then we'll look at people who have kind of more experiential knowledge and talk about their role. So I'll just ask you if you can cast your mind back for a week. What was the difference? What's the difference between the social model of health, the biopsychosocial, and the biomedical? Very roughly. Pick any one point about any model. Yes. Okay, yeah, thank you. That's a good contrast between the biomedical. So the biomedical kind of focuses on the pathology in the individual, whereas what I just heard you say about the social is that you're looking at a much wider range of factors. So we'll talk about social determinants in a minute. Where does this biopsychosocial fit? Anybody? Because your textbook actually, your textbook is quite heavily biopsychosocial, except for chapter 5, which you've been reading for this week, where you've got Karen Willis, who's putting forward more of a social model. Anybody make a stab at that one? I mean, the biomedical model is a sort of abstraction. I mean, there's almost nobody who doesn't agree that, you know, people's well-being and health is connected to their psychology, their emotions, and social factors. So, you know, a lot of my friends are doctors, and they all say, you know, what's a health sociologist? Somebody who goes around bashing doctors. I mean, I'm not saying that most practitioners will acknowledge the biopsychosocial, but the point about it is that it's focused on the individual rather than the whole society. It's more of an individualistic focus. Okay, so can somebody tell me what the social gradient of health is? Somebody different. Okay, so you remember all those bar charts that Kate showed you last week. So does anybody remember what the denominator is? What are those bar charts based on? Could be a time one, yeah. Yeah, most of them are based on, well, I think the ones she looked at were quintiles, income, education, socioeconomic status quintiles. And the social gradient demonstrates that for a lot of different things, a lot of different health conditions and a lot of different health behaviours, there's a social gradient in that people who've got less money, less power in society tend to have worse health. And the point about that is that that's the case even in the UK, which has a completely free universal health system. So that relates to social determinants. So what is creating this social gradient in health if it's not just access to healthcare? Anybody brave? Okay, so you remember the WHO definition of health? It's about the working conditions, living conditions, the food you eat, everything about your life is feeding into your health. Your access to healthcare, especially most of the healthcare we're going to look at today, is tertiary care. It's people who've already got sick. So the social determinants approach is saying hang on a minute, you know, how come we know there's this pattern and we're not stopping people from getting sick? There's a very well-known analogy, which is, you know, what we do is we send an ambulance to the bottom of the cliff. We pick people up all the time because they're sick, but we don't go to the top of the cliff and build a fence or a warning sign. We don't stop them from falling off, we just rescue them when they have. So the social determinants is about mapping everything about the way that society works to see, well, you know, how could we prevent some of this health? And the interesting thing from a sociological point of view, and maybe from a practitioner point of view too, is that a lot of what we're talking about is a sense of powerlessness. So people who are at the top of the socioeconomic status ladder, they're not just healthier because they can buy better food, they also have more of a sense of empowerment. So if you do health promotion, you're going to get much better take-up at the top of the socioeconomic gradient than you are at the bottom. Okay, so that was last week. So let's have a think about the healthcare system. So when I teach this, I've taught this for a long time, and people have different experiences of the health system. You might personally have a health condition, or you might have a family member with a health condition. You might have a lot of interaction with general practitioners or physios or the hospital, or you might be somebody who is very, very healthy. Your mum and dad have always kind of paid for you to go to the doctor. If you needed to go to the doctor, it's something you've never had to really give any thought to. So the healthcare system is a social determinant in itself. I've pushed very hard the social determinants, that social determinants are making people sick before they ever get to the healthcare system. But if they can't access the healthcare system for one reason or another, that is going to definitely affect their outcomes. And this is a fairly long quote from Parry and Willis, which is your chapter. Countries with free universal health systems usually have lower mortality and morbidity rates than those that rely on market-based systems. So and that's partly because people have access to preventive things, and particularly it supports things like free immunisations and support with chronic illness. So people's access to the healthcare system certainly interacts very strongly with the social determinants approach. So if we think about the different kinds of healthcare systems there might be, this is Duckett and Wilcox, who are the main sort of health policy people in Australia. You want to think about equity, efficiency, quality and acceptability. So obviously we all want a healthcare system where people get very good quality care, and your education's aimed at making sure that you're kind of very, very competent practitioners. On the other hand, we want to have a system that's efficient. We don't want to be spending huge amounts of resources on unnecessary tests or unnecessary investigations. The government can't afford to have, and there's a constant struggle about this, is the ratio of nurses to patients, or the number of doctors, number of allied health practitioners that we have. So we want a steady throughput and not waste money. And we've also got to adapt to changes in requirements. So in Australia, we've got a lot of debate about how do we adapt to changing need for psychological services, like, for instance, putting in facilities like Headspace. Equity. So there are countries in the world, particularly developing countries, where some people have access to first world healthcare, and other people have very little access to healthcare at all. I knew someone who lived in the Philippines, and the Philippines, if you could afford to pay, you got American standard healthcare. If you couldn't, then you had no access to medications, even vitally necessary ones, and a very poor standard of care. So, obviously we don't want a health system that's like that. And then acceptability. So, health system is part, what people will vote for will depend on what they find important, what their values are, and basically how much political and social support you can get for changes in a particular healthcare system. And one of the key things that we've got in Australia is this balance between public and private. And I'll talk a bit more about that in a minute. And so one of the things that the private system always says is, in the private system you can choose your doctor. Now in the public system you're actually getting pretty much the same doctors that you've got in the private sector, but you don't get to choose, you get whoever is on. And so that's a big, for some people that is a value. I want to go to Dr. X, I don't want to be told that I have to go to somebody else. So other issues that are important are whether or not everyone has health coverage. So we'll look in a bit about the American system and discuss the reforms that have been happening over there. But it's been a kind of a keynote thing for a long time that the American health system is very expensive, but an awful lot of people are not covered by it because health insurance is linked to employment, and the Medicaid, which is the safety net system, it has a very, very severe means test, and there's a whole lot of people who are insecurely employed who up to now have not had access to healthcare. The other thing that we value in Australia is that we wouldn't expect somebody to be bankrupted by healthcare costs. I think most Australians would find that kind of unacceptable. Now the primary healthcare system is an important part of the healthcare system, but it's somewhat under-recognised. When we think about the healthcare system, we tend to think about the hospital system, but an awful lot of allied health and a lot of frontline healthcare is provided by general practitioners, nurse practitioners, practice nurses, physios, dietitians, occupational therapists, who are all out in the community and who are sort of part of this frontline system. And one of the points that sociologists make is that this area of the healthcare system is somewhat under-recognised in the Australian system. So what I've been saying is that the healthcare system, the design of it, the way that we fund it, represents our priorities and what we find acceptable. An ideology is a set of beliefs and values, and so in Australia we've got a debate really between freedom of choice and equality, or individualism versus collectivism. And in some ways the Australian system is like a seesaw. It's kind of very evenly balanced. So we have private system and private health insurance, which is about freedom of choice and individual responsibility, and we have a public system which is about collective responsibility and trying to work towards equality. And those two things are constantly balancing. Now, for the last 25, 30 years, we've had an ideology of neoliberalism in Western countries, which has encouraged governments to outsource, to not employ people directly in order to provide services efficiently. And so that ideology has been part of the tussle around how we're going to deliver healthcare services to everyone. So the healthcare system is complicated. It's got a very big employer. It's one of the biggest employers in Newcastle. It's one of the fastest growing areas of employment is health and social care. And so everybody who works in it is part of the system, how they're trained, how their institutions are organised, whether or not they are big bureaucracies, whether or not they are smaller institutions, whether they're kind of private sector or not for profits. The government is constantly planning and negotiating, and we'll see in a minute that it's particularly complex in Australia because of all the different levels of government. And we'll look at how healthcare is paid for in this country, and you might be surprised. I don't know how you think healthcare might be paid for here. Does anybody who hasn't looked at the PowerPoint so far want to make a stab at what proportion of overall health expenditure in Australia is paid for by private health insurance? 40%? Okay, all right. Remember that figure and we'll have a look. Okay. Okay, so as I said, what we're talking about here is the outcome of debates over the years and the values that Australians attribute to health. So, who should be responsible for healthcare? Should it be the government, the private sector, individual people, the medical profession, or the community sector? So, thinking about the social model of health and the social determinants of health, who do you think should have responsibility for healthcare in Australia? We think about what we talked about last week about inequality and inequity. Whose responsibility is it to do something about that? The government is pretty well going to be a leader, I think, in public health. But the private sector, as we've said, in Australia is a valued part of that people, I think people in Australia would, and I'll talk a little bit about the history of this, people in Australia would find it unacceptable if you said, we're going to withdraw all funding from the private sector. You know, in Britain, there is a private sector, it's very small, and if you have private health insurance, you have to declare that before you go into an NHS hospital. You don't have the option of using the NHS. If you have private health insurance, you have to draw on your health insurance first. So we've got a rather unusual setup here. Individuals, well, part of the point is that any one of us could walk out of here and have a car accident, or we could have an investigation and find that we're suffering from a degenerative disease. It's very difficult for us to be responsible for catastrophic healthcare costs. So part of the communitarian basis of our healthcare system is that we should be responsible for each other so that nobody ends up bankrupted by their healthcare costs. But obviously it is important for people to take individual responsibility. It's just that when you see that social determinants, it's much easier for people who've got resources to be responsible than it is for people who are coming from behind in terms of their education, their income, or where they live. To what extent are medical professionals responsible for their healthcare system? Do you think they have? Do you think the groups that you're training to belong to have an important role in shaping the healthcare system? have a think about that, and we'll talk about that in the second half. And then the community sector, which plays a very, very large role, especially we'll look at the NDIS, and the not-for-profits and charitable organisations have a big role to play. So I'm just going to play you, if it works, now this is a little overview of the Australian healthcare system. I'm not 100% sure who it was aimed at. I rather think it's for expats coming to work here, explaining how our system works. So it's sometimes useful to hear something that you're very familiar with explained for the benefit of other people. Oh, sorry.
The aim of Australia's healthcare system is to provide access to health services for all Australians at an affordable cost or at no cost. Private health insurance is not compulsory, but the Commonwealth Government offers incentives to those who take out private cover. The premiums for private health insurance vary depending upon the state or territory in which you live, the type of coverage required, and the number of persons being insured. There are both public and private hospitals in Australia. Pressure for their services means most public hospitals have waiting lists for elective surgery. Public health is a mixture of public and private, with the public system dominating. Healthcare starts at the general practitioner, the local family doctor, where a visit costs between $35 and $65, some or all of which will be covered by the government through the Medicare system. Specialist and hospital care can also be accessed through Medicare, which is funded by the taxpayer. Most common prescription items are subsidised by the Commonwealth Government, greatly reducing their cost. If an item is not on the government subsidy scheme, the cost to the consumer can be substantial.
Okay, so that's just a little snapshot of our healthcare system, and as the point that it made was that we've got our healthcare system is dominated by government provided services, and even things which are provided by private practitioners like general practitioners or specialists are subsidised through the Medicare system. So we have a universal access system, but the difference between the private system and the public system is that sometimes you have to wait in the public system because it's prioritised on need, not on ability to pay. So how did we get to the system that we have now? We're talking here about the history of white Australia, starting at late 18th century. There wasn't very much effective medical care. The doctors who came here with the early colonists would have been army doctors, and they were the predecessors of surgeons now. So most of their training was about battlefield injuries and cutting off legs without anaesthetic. So and then there were opium painkillers. That was basically it. There wasn't much in the way of effective medical care. So that European system was brought here, but the medical system was not very well organised. It was around the government, and most people wouldn't have ever seen a doctor. Most care would have happened in the home. Maybe people had herbal remedies or home remedies. In the course of the 19th century, the medical profession in Europe got more powerful and more well organised. They got a monopoly on signing death certificates. They organised themselves from apothecaries, physicians and surgeons into a more unified medical profession. And so they became quite a powerful group in the 19th and early 20th century. As urbanisation happened, there was more poverty. People opened charity hospitals. There were, in Australia, of course, we've got a long history of charity hospitals run by the Catholic Church. So if you were wealthy, you had a doctor come and visit you at home. If you were poor, you went into a hospital. Beginning of the 20th century, you start to get more scientific medicine. They've discovered antisepsis, anaesthesia. The system becomes more organised, and the doctors really are at the head of it. So there weren't really many allied health. There was doctors, there were nurses. The doctors were in charge of the system. They tended to run the hospitals, and they were. And at that point, people started to worry about whether or not everyone had access to this increasingly effective medicine and these hospitals. So then you had a private system and a charity system. So if you were poor, you could get access to free care as a charitable kind of pro bono. So the doctors would have access to the hospital for their private patients in exchange for running free clinics. If you were an Aboriginal person, you had to wait on the veranda because you weren't allowed to kind of wait in the clinic with the white people. So that's where we're at in the sort of 20s. Between the 1920s and 1940s, over the Depression and the Second World War, and in the aftermath of the Second World War, people started to think about how could we change this so that everyone has access to healthcare. And in Britain, that's when they brought in the NHS. In Australia, there were a lot of doctors who were refugees from Britain who didn't want to work in the NHS, and it was the British Medical Association, it became the Australian Medical Association, was vehemently opposed to having a national health service. So that's why we've got this balanced system, because they made it impossible for the Australian government to legislate for a national health service. So in the 50s to the 70s, we had state subsidised insurance for everybody that could afford it, but that still left a lot of people out. So then we get Medicare that comes in the 70s and is finally instituted in the 1980s, and we've had that ever since. But you can see from this history that we've got this pull between the public and the private. So we have a rather paradoxical situation where we have a 100% free universal system and a private system running alongside it. And sometimes the rate of insurance goes down and everyone gets worried that the private system will disappear, and then sometimes people say, well, the public system's overcrowded, we need more people to have private health. So Medicare, as you know, is national, universal, everyone has access to it, and it's managed by the federal government, and it covers all of those things. So I don't need to read that for you. You can see that it's some diagnostic imaging, some dental care, eye checks but not glasses as a rule, allied health in limited circumstances, some medical services for private patients in public and private hospitals, but it guarantees public patients free treatment. And we also have the pharmaceutical benefits scheme, whereby the government negotiates the price of our pharmaceuticals with the big drug companies and also subsidises the price. So countries like Australia and Canada that do that have much cheaper pharmaceuticals than somewhere like the United States, where it's a major problem to access reasonable. Now, it's universal, but it doesn't cover absolutely everything. So private patients, dentistry is the major standout. And in terms of social gradient, it it is a real mark of poverty if people cannot, and you don't have to be terribly poor to not be able to afford dentistry, but not having good teeth is a major barrier to employment, to good nutrition, a whole lot of things like that. So that is a big gap. And a lot of the allied health that, you know, you're training to be part of that, those occupations is not covered by Medicare either. So you might be interested to know that we do have a reciprocal arrangement with various countries to provide medical services. So if you're in Britain and you're Australian, you're entitled to use the NHS. And I think if you'll find in your chapter it says there's a list of other places too, like Sweden, and those people can use Medicare as an exchange. Okay, so in a minute you're going to see that actually Australians pay, even though we've got a universal system, we pay a lot of out-of-pocket costs, higher than the OECD. So why is that? Well, it's because Medicare is working on a schedule of benefits that it pays to doctors. The doctors are all private. It is not possible for the government to legislate to cap medical fees. So the original idea was that the government would have a schedule, they would reimburse 80%, or the doctor could bulk bill, in which case the doctor just kept the 80% and didn't bother to collect any the 20%. Now, for budgetary reasons, the schedule of reimbursements has been kept very low, so almost all doctors charge over the schedule fee, and that's why people end up with a lot of out-of-pocket expenses. Also, if you have private health insurance, you will often get a gap for the anaesthetist, the surgeon, and people are often surprised how much they end up paying. Interestingly, the gap is much higher in regional areas than it is in big cities, because in big cities there's more competition. So this is a sort of major thing in Australian public life and debate, is how much are people paying if they are in the private system. If you're in the public system, there's a very long wait for elective surgery, so a lot of people do go into private system for that sorts of things. So we've got a very complicated system. We've got the Australian government, the Commonwealth government, we've got the state governments which run the hospitals, but they don't raise all the money, they get half of the money from the federal government, and so there's a funding agreement that lasts 5 years that keeps being renegotiated. And we've got local government who actually provide a lot of the services that keep people healthy, like clean water, sanitation, food inspections, all of those really kind of social determinants. The governments share a lot of public health, cancer screening, and regulation of health practitioners. So your set reading for this week is from the Australian Institute of Health and Welfare. This slide is the 2016 report, which is very concise. There's a 2018 report, which I've also put up there, which is a lot more detailed and in some ways less clear, but the information is very similar. So I would read the 2016 one first and then just have a look at the 2018 one. So to summarise a lot of what we've been saying, and just to demonstrate how complicated this is a really lovely diagram which isn't in the 2018 report, which I think is sad, which shows you that we're spending, now this is everything that's spent on health. This is 2013-14, but the 2015-16 figures won't be substantially different. So 40% of everything, public and private, individual and corporate, that goes on hospitals, of which that's the Commonwealth That's the states, that's private. Here's the private hospitals, privately funded this much, Medicare that much, community and public health is down here, dental services mostly private as you see, Medicare, private and Commonwealth, medical services non-referred, other health practitioners. So other health practitioners, very small amount, so that's Commonwealth and private out of pocket. Medical services referred, so that's all the specialist services, administration and research and other health. So we're spending 38% on primary care, of which very little is about public health. Obviously there's a lot of prevention goes on in primary health care, but we don't spend an awful lot devoted to it. Hospitals are the dominant expense and other services. So again, this is 2013, but I've checked, if you look, the 2015-16 figures are not that different. 68% is funded by the government, of which 41% is Commonwealth. Now, 18% is out-of-pocket expenses, and 8% is paid for by private health insurers. So do you remember we said 40? So you're right in the sense that 40% is private and 60% is public, but 18% is out of individual pockets, which is a really, I'm glad you said that because it made the dramatic point that I was aiming for. So we are actually well over the OECD average in terms of individual contributions to health. So what's the outcome of having this very complex mix of private and public provision? It means it's difficult to develop comprehensive policies about mental health or prevention. People who are in the system are kind of using private health insurance, they're going to the general practitioner, they're going to the hospitals, they might be going to an NGO. There's a difficulty coordinating. There's attempts to create plans and care plans that go across these different levels. But, you know, it would be lovely if someone needs, you know, a GP, a physio, a psychologist, that they had very easy access and it was a very simple system. There's a lot of blame shifting. So, you know, if there's a problem with mental health, the Commonwealth will say, well, the states should be doing more. The states will be going, no, this is a Commonwealth problem. The Commonwealth could give the states money and they don't necessarily spend it on what they want them to spend it on. So it's a bit unwieldy. So overall, it's a fragmented system. It's not. It's difficult to introduce comprehensive new policies. There have been suggestions about 10 years ago, suggestion that the Commonwealth should take over the whole health system. I mean, we only have 25 million people. Admittedly, we're very widely spread, but if we took the states out, then you would only have that one level of government. I don't know. There are probably pros and cons for that. The other point that sociologists and your chapter will make is that, to go back to that, you know, fence at the top of the cliff metaphor, we're spending an enormous amount on treatment and not so very much on prevention. So, coming from this history of kind of, medically oriented, acute care, we've now got this situation where the system tends to revolve around hospitals. That's what people tend to think of when they think of the health system, rather than the management of chronic illness. And as you saw last week, the vast majority of the burden of disease now is in chronic illness, and we don't So it's difficult for us to extract money from this very big system and say it would save us money if we were investing more in high quality housing, good quality childcare. And we're not necessarily addressing the kind of inequalities that Kate talked about last week. So this brings us back to the picture that we looked at last week of inequality and who is missing out, who is disadvantaged. The other important issue about this balance that we have between the private and the public is the issue of whether or not Medicare is valued as a universal access system. Because in systems where the public system is seen as a residual, a safety net only for the poor, and people with good jobs and good incomes tend to go only to the private system, then the pressure to improve the public system falls off, and you enter into a downward spiral. Now, at the moment, you're not allowed to opt out of Medicare. If that was a policy direction adopted, then the fear would be that the public system would become a residual system at the expense. So the private system would increase, but it would be at the expense of the public system, and that would make these access and inequities much worse. Okay, so I'm going to show you the beginning of a video that explains the NDIS. So the NDIS, in a way, is a kind of interesting case study of policy reform. So the health system is wrapped up around the acute system, a large primary care system which is dominated by general practice. But in the last 10 years, we've had this big change in the way that we're providing disability services. And this is something that guarantees, or is meant to guarantee, services to the individual. So I'll show you the video, and then I'll just make a couple of remarks about how that relates to the kind of issues we're discussing.
Insurance scheme, NDIS. This symbol is you. When you are eligible for NDIS support, you are called a participant. This video will help you understand the path you will travel as the NDIS works with you. It will provide an overview of what to expect at each stage. It's important to understand how the NDIS works and whether you are eligible to participate. So, what is the NDIS? The NDIS is a new way of providing disability support. It takes a lifetime approach, investing in people with disability. The NDIS supports people with disability to build skills and capability so they can participate in the community and employment. You can access the NDIS depending on your age, residency and disability. You need to be under 65 years of age, live in Australia and be an Australian citizen, or have paperwork that gives you permission to live here permanently. Your disability needs to be likely to be with you for life and substantially impact how you manage everyday activities. Your first step, once you access the NDIS, is to create your first plan. Your first plan is the start of a lifelong relationship with the NDIS. It will continue to give you the support you need now. It will make sure you have time to learn more about all of your options with the NDIS. Your first plan will give you time to think about what you might need to help you achieve your goals before you do your next plan. Your plan may include informal supports, the care and help you get from your family and friends, community supports, the activities and services you can get from people or groups in your local community, mainstream supports, the support and services you get from people like doctors and teachers, reasonable and necessary funded supports, the supports and services the NDIS can fund. Your first plan will be in place for 12 months. This will give you time to think about how those supports are working for you. Once your plan is approved, it is time to put it into action. The NDIS can work with you to help you start your plan. With the NDIS, you can self-direct your plan. Self-direction means you have control over your supports and how they are provided, including payments to your providers. You can choose the providers you want to deliver the services you need. Your existing provider may need to continue to deliver some supports initially. You will normally need to make a written agreement with your providers. You can access your plan on the Participant Portal, an online tool available through the MyGov website that keeps all of your documents together. While you are starting your plan, you might like to think about your future goals and consider activities and ways of achieving them. While everyone is different, your first plan will generally be in place for 12 months before we work with you to make any changes. This is called a plan review. To get ready for making your next NDIS plan at your plan review, think about your life now, including which supports are helping you and which are not. Identify your strengths, interests, opportunities and challenges. Consider your current informal, mainstream, funded and community supports. Think about your goals and what you want to achieve. Write this down so that you are prepared for your plan review. The NDIS will support you throughout your life for as long as you need it. So this pathway will continue on and you'll update your plan as your needs change. For more information about this video, please contact the NDIS. Visit the NDIS.
Okay, so if you just think about what you've just heard, what's interesting about this? So what do you think are the pros and cons of putting services like this into in the form of the NDIS? What's the big plus that they're advertising there? Yeah. It's helping an individual person. It's very much emphasising kind of that person's power to choose, isn't it? It's making. I mean, that's obviously a PR video. I mean, it's very upbeat. It's very, you can choose, you can make choices, and we want to kind of get you back to work and make you able to participate. Those are all really positive things. They're about empowering. They talk about the kind of social supports, don't they? They kind of they build this picture around the person of family, community, health professional, and then the NDIS. What might be some of the downsides of this, or the problems with it? That's true. Well, we know that there've been problems rolling it out, and the year might be too long. As well as giving the person a lot of choice, it's giving that person a lot of responsibility as well. So maybe not everyone is going to be able to, get online and review their plan, and it's very, it's sort of assuming a lot of agency on the part of the disabled person. So in one way that's good. We want people to feel in control of their lives, but not everybody is going to be able to take advantage of that. I've got some personal experience of doing research with older people who are doing a similar thing with aged care. Now that involves, you've got to be computer literate, you've got to get on the system, you've got to understand what your choices are, and the other thing too is the amount of money. If it's taken up with a lot of physical care, there may not be very much left over for a lot of the kind of bells and whistles. But so sociologically speaking, what we would say is that in some ways this is addressing issues of, it's trying to coordinate across systems, so that's really good. It's trying to empower individuals, but it's very much based on that kind of individualistic, sort of market-based, user pays. So the government is really giving you the money to buy your own services. Now, there's a lot of opportunities there for non-government organisations and individual practitioners to bid and create small businesses. So that fits very much with that ideology, as opposed to having a big bureaucracy. But you can anticipate that there might be some problems with people actually using that system. And we know that because it's user-driven, this is the week to actually, they've actually announced the budget figures that they have actually underspent on the NDIS because people are not engaging with it. They're not demanding what they have a right to, what they have a right to get, and so that seems a bit of a shame. We don't know where the shortfall's coming there. Okay, so let's look at another alternative to kind of large acute-based systems. This is Professor Brown, who graduated from University of Newcastle. She's a medical doctor. She graduated from here in the 1990s, and she's a big spokesman for Aboriginal Control Health. So this is another way of providing services to groups who are marginalised. Sorry, my links are a little bit clunky.
So my name is Nairi Brown. I'm a Yuin Nation woman from the south coast of New South Wales. So my grandmother and my father's country is around Shoalhaven in Nowra. I'm a doctor by trade, but when I want something I'll use professor. And I'm currently doing consultancy work for Wananga Nimitja, Aboriginal Health Service in the ACT, but I work generally in Aboriginal health, in research, in policy and advocacy. I mean, I have a real interest in child and adolescent wellbeing and all of that encompasses, so that we know that the very early years, even from conception and preconception, are incredibly important. But if we look at from the very first breath, even to the third birthday, for example, the way that our children grow and develop and their pathways are being, developed is incredibly important. And also adolescence, it's a key transition period. So we always talk about how important it is, and yet there's very little work in that area, particularly for Aboriginal and Torres Strait Islander mobs. So how do we look at the social, the emotional, the physical and the cultural development of our young people? How do we support them, build resilience? How do we connect them with culture so they have a better sense of self, of identity, and then we can actually improve their outcomes across the social and cultural determinants of health? If you look at the way in which we've been able to develop services that are specific to Aboriginal and Torres Strait Islander people, but also are inclusive of all others, I think we actually do things better. We come from a perspective that isn't just medically orientated, but it's very much about the social environment, how people are in terms of their health as well as their well-being and what that means, where they're living, how many people that they're looking after, all of the other concerns that they have as part of, day-to-day life. We all do it, right? But if you look at the way in which Aboriginal services, our health services in particular, have been developed, they're inclusive, they are comprehensive, they don't just deal with individual body parts or particular issues or writing scripts for one disease only. We try and provide the platforms and the supports for people and the way that they exist, taking into account all of their history and what we hope for their future. And so I think that historically Aboriginal services were developed specifically for our mob from a political perspective as opposed to a purely health perspective. Does that make sense? but they've evolved over time. And so by having our own services, we know that we are more culturally competent, we are inclusive, we have staff and other practitioners, Aboriginal and non-Aboriginal, that understand the experience, you know, whether it's empathy or whether it's lived experience of Aboriginal staff, then they know we're starting from the same point going forward, and then hopefully we're able to provide better services. And quite frankly, I think the way that we do things in Aboriginal services can actually enrich practice across all disciplines, but particularly in health. So whether it's a primary care service or a secondary or tertiary referral centre, if they were to be as inclusive, if they were to better understand their clients culturally as well as socially, they're better connected in terms of that continuity of care and an interest in the pathway of the individuals and the families that actually become part of their practice, then we would actually have better outcomes for Aboriginal mob, but for everybody that accesses those services. I think there are some measures for which we've been able to do particularly well, and I know there's reporting on the reduction in the disparity in life expectancy.
Okay, you've got the link to that one. I don't want to run out of time, so I'm going to cut that one short a bit. But just the take-home message for that really is the NDIS is an insurance-based, it's very much focused around the individual and about empowering the individual, which in principle is really, really good, whereas Nairi Brown is talking much more about a much more community-based, holistic service that includes lots of different practitioners to meet the needs of a group of people, and they're sort of extended networks rather than focusing on the individual. And I'm not knocking the NDIS, I think it's a great achievement, and I really hope that it's going to fulfil its promise. But I think there's things that we can learn about both of those, but both of them are about people's life across the social and the psychological and the biomedical, not just focusing on one aspect. So I'm going to finish this section by looking at contrasting us with a couple of other health systems, which I've already referred to, and then we'll take a break and then we'll talk about professions. Okay, so this is a very well-known comparison about health performance and healthcare spending. So if you have a look at, it's a bit difficult to read the diagram, but the main take-home message is that most of the kind of developed democracies are spending around about 10% of their GDP on health. We spend 10%. It's gone up from 9% in about 10 years because we have kind of expensive treatments and aging population. The United States is way, way high. They're spending 17, 18% of their GDP on health. That's because they have a privately based system. The government really, they don't really have a system. They have an industry that's largely based on for-profit hospital chains, and the government has very little control over health expenditure. We'll have a look at what attempts to reform that. Australia, we're number 2 here, overall ranking. We've got a 4 in access, so that's not so great. And a 7 in equity. So if you go across, Norway is 4 overall, 10 for care process, access, equity. Have a look, the UK is number 1 for overall care process, access, administrative efficiency, but number 10 for healthcare outcomes. The US ranks 11, and that's because it's got very poor equity. So the UK, I grew up in the UK. I didn't come to Australia till I was 32. I'd never paid a doctor's bill. I'd never seen a doctor's bill. I'd never even thought about doctor's billing. Everything that I'd had, including my not very good dentistry, was completely free. So after the Second World War, the NHS was brought in. It was strongly resisted by the medical profession at the time, and as I said, a lot of people came to Australia to work because they didn't want to work in the NHS, but it's now very strongly supported by the medical profession. You don't pay, there's no actual billing process. You just go, you're entitled to care, but you may pay small co-payments for drugs, glasses, dentistry, includes allied health. It's under strain at the moment because Britain, as you know, is going through a political crisis. It's had 10 years of government austerity. The CEO, they've tried to kind of introduce private sector management practices. The CEO of the Tyne and Wear Health Authority just quit and said, life's too short, I can't cope with this job. So things are not swimmingly, but anecdotally, I mean, in terms of stats, they still do very well under huge pressure. You get anecdotal stories of Americans turning up in Britain and saying, I can't believe that care of this quality is just available for nothing. So it's a much loved institution. The idea of privatising it horrifies almost everybody in Britain. It's used across the board. Only really wealthy people have private health insurance, and there's no overlap. If you're private, and you pay for everything. There's no kind of cost subsidisation the way that there is in Australia. Okay, so in the United States, as you know, President Obama came in with great hopes that he would transform American society. Possibly the only thing he really managed to get done was healthcare reform, and it was a very quite a limited, in global terms, quite limited, because what he did was to say that everybody must have some form of health insurance. I'm going to show you a little film of him talking about it. It's still an insurance-based system. There's still no caps on medical fees. They're still paying huge amounts, and it was very controversial. Just like in Britain, there's a huge value for the NHS. In America, there's much more value on freedom, and the idea of the government telling you that you have to have health insurance was an anathema. So I'll just play you a little bit of Obama, and then I'll talk to you about what's happened since.
Needs to know about this plan. First, if you are among the hundreds of millions of Americans who already have health insurance, nothing in this plan will require you or your employer to change the coverage of the doctor you want. Under this plan, it will be against the law for insurance companies to deny you coverage because of a pre-existing condition. As soon as I sign this bill, it will be against the law for insurance companies to drop your coverage when you get sick or water it down when you need it the most. They will no longer be able to place some arbitrary cap on the amount of coverage you can receive in a given year or in a lifetime. We will place a limit on how much you can be charged for out-of-pocket expenses, because in the United States of America, no one should go broke because they get sick. And insurance companies will be required to cover, no extra charge, routine checkups and preventive care, like mammograms and colonoscopies, because there's no reason we shouldn't be catching diseases like breast cancer and colon cancer before they get worse. If you lose your job, or you change your job, you'll be able to get coverage. If you strike out on your own and start a small business, you'll be able to get coverage. We'll do this by creating a new insurance exchange, a marketplace where individuals and small businesses will be able to shop for health insurance at competitive prices. Now, for those individuals and small businesses who still can't afford the lower-priced insurance available in the exchange, we'll provide tax credits, the size of which will be based on your need. For those Americans who can't get insurance today because they have pre-existing medical conditions, we will immediately offer low-cost coverage that will protect you against financial ruin if you become seriously ill. This was a good idea when Senator John McCain proposed it in the campaign. It's a good idea now, and we should all embrace it. But an additional step...
Okay, so As you may or may not know, the first thing that President Trump wanted to do was to abolish Obamacare, and he said he could put in something better. And Senator John McCain, who is now dead, voted against it. He voted it down in the American Senate, so they still have Obamacare. It's an insurance it is an insurance exchange to try to address some of the major inequities in the United States system. Unlike, you may not realise, because I didn't realise until I came here, but in Australia, our private health insurance is community rated. We all pay into it, and admitted, there are exclusions, so you have to wait more than 9 months if you want to claim for a baby or, pre-existing conditions. But once you're in it, we all pay into it in the same way. Whereas in America, it's like car insurance. If you're sick, you will be paid you will be charged a higher premium. And also, most people, if you've got a good job, if you work for Microsoft, you'll have fantastic health insurance that pays for very high level care. But if you lose that job and you've got a child with a chronic illness, it'll be difficult for you to get health insurance again. So that's the Obamacare reforms. I'm not an expert on them, but the general principle was to try to even out some of those inequities by giving people access to health insurance. Their provision is still, what public provision there is very underfunded, so their provision is still almost entirely in the private sector. So it's still very expensive, but the Obamacare reform was designed to try and even out some of the inequities in access to health insurance. And it will be, watch this space, see what happens. Okay, just take 5 minutes. Probably not enough time for the coffee cart, but enough time to take a break, and then we'll talk about health professionals. Okay, so I'll just start the second half now by talking about what profession means sociologically. So professional has become a word that means really, someone who works in a competent way. So our administrative staff in the university are now all called professional staff, not general staff, and that's fine. I don't mind them kind of getting that status. But sociologically, professions were a particular kind of occupation. And the traditional professions were the law, medicine, higher education, and the church. And the idea of that was that all of those occupations had very high levels of autonomy and prestige. Now, the church has taken a bit of a dive. Higher education is, much more of an industry than it used to be. The law is still very autonomous, very private. I mean, we could talk about access to justice as well as access to healthcare. The medical profession still has a lot of authority, but maybe not as much authority as it used to have. So that's what we're going to talk about, really. So what makes a profession? So professions are traditionally defined as having a body of systematic and generalized knowledge. They're meant to be altruistic. Now, some sociologists have questioned that and said, well, actually, they're also kind of very high-level trade unions who, look after the interests of their members and make sure that they get paid well. They're meant to be altruistic, and this was a contrast between the idea of going into a profession, which was to serve people, as opposed to going into a business, which was aimed to make profit. But of course, as you see in America, there's a lot of profit to be made in healthcare. Professions are supposed to be ethical. So they're usually self-governing, and they're meant to have a code of ethics. Now, most medical professions and most health occupations now are registered with the government, and there are healthcare complaints commissions and other mechanisms which govern them. They're not allowed to be completely self-governing. And high rewards, prestige, money, well, that certainly doesn't apply to the church. It's less to the universities than it used to be. Still, law and medicine are pretty prestigious occupations. But we know that the health workforce includes the very largest group of is the nursing profession. Nurses and midwives, there's sort of nearly 300,000 of them. Sorry, that's very small. You can find this in the AIHW. Okay, so we've got Chinese medicine, chiropractic, oral health, 17,000 of them, 80,000 medical practitioners, 11,000 MR medical radiation, 13,000 OTs, 4,000 optometrists, 1,500 osteopaths, 21,000 pharmacists, 3,000 podiatrists, 23,000 psychologists. Has I left anyone out? No nutrition and dietetics people down there, I'm sorry. Okay, so that gives you a bit of a sense of the, that was 2013, so you can see the increase to 2016, creeping upwards with the population. And so the other issue that's become important in the health system is this idea of practicing from evidence rather than from authority. So this is one issue where it used to be that you passed your exams and then you practiced for the rest of your life, and you did what the people who taught you did, which meant that people's idiosyncrasies or their knowledge got out of date, whereas now we've got much more of an evidence-based practice, and we've got a hierarchy of evidence, which you're probably very familiar with the randomized controlled trial at the top, and expert opinion, including consumers, but much less prestigious. But there is an argument there also that in the social model of health, the research evidence, the practitioner expertise should also be taken into account with service user preferences and values. Evidence-based practice has always said that it should be modified by people's values. So, as I said, medicine's one of the traditional professions, and the idea was, in the middle of the 19th century, they made a social contract between the profession and the state, that they became the gatekeepers to care. And medical knowledge and medicalisation has become very prevalent in our society. And there are many conditions for which people want to be medicalised. So many people think that ADHD should be a medical diagnosis or is a medical diagnosis. There are other things that are less clear, like chronic fatigue, because getting a medical diagnosis like that allows you to access particular kinds of health, particular kind of care, have time off work. So medicalisation is quite a powerful process, but it may not be the most appropriate one for chronic diseases and mental health conditions. And the medical profession has been transformed by consumer movements, particularly the one that I'm interested in, which is the natural childbirth movement, evidence-based practice, and the pharmaceutical industry and professional independence. So there have been a lot of threats to that traditional medical dominance. This looks pretty, but it's difficult to read, isn't it? So these are the traditional sociological reasons why the medical profession has been dominant in the health system. And I kind of leave it, and that's defined by, as I said, its autonomy over its own work, its authority over the work of other professionals, and its prestige in society. But the women's health movement, patient advocates, the fact that people can access health information on the internet, privatisation, so large commercial general practice companies moving in, all of those things have challenged traditional medical dominance. We've got more clinical governance, corporatisation, the government monitors Medicare to pick up doctors who may be doing the wrong thing, and increased competition. So other highly educated groups, like the ones that you belong to, nursing, allied health, complementary medicines, are all wanting to carve out their own area of expertise and practice. This just demonstrates the number of medical practitioners in Australia, the number employed, the proportion of women. So there's a lot more women working in medicine, and they tend to work part-time. As I said, nurses and midwives are the biggest group, and you know, when I teach the midwifery, I teach the nursing students, there are 700 in a cohort, because that's the biggest number, the biggest proportion of the health workforce. But we've got a range of allied health as well, and you might argue that if you are going to provide comprehensive services to people across the board, then access to allied health is equally important as access to other forms of healthcare, particularly because many allied health practitioners, physios, nutrition, dietetics people, are working in the community. They've got skills to help people prevent chronic illness or alleviate chronic illness, and So they are really part of primary health care. And that's 9% of the health workforce at the moment, but it's growing. So here we are. These are the registered practitioners: psychology, pharmacy, physio, OT, MRT, optometry. Interestingly, and I'll talk about this in a minute, that we actually register chiropractors, Chinese medicine, and osteopaths, because in the 20th century, those occupations were excluded, and that was one of the marks of medical dominance. So, allied health professional autonomy, the word allied health sort of implies, it's sort of like the ladies' auxiliary, that they're there to assist the medical profession, alliance with and subordination, and most people worked under a medical director. So the sociological argument is that the allied health professions are actually banding themselves together to become a more powerful force in society to argue for the importance of their services. Another important part of sociology of health and illness in Australia and other countries like it is the rise in complementary and alternative medicines. So the allied health professions tend to work within established scientific parameters, though they, to a greater or lesser extent, can adopt the social model of health, whereas complementary and alternative medicines tend to operate somewhat outside established scientific knowledge. They argue that they have their own body of knowledge, and their legitimacy is really based on the demand. People who are disillusioned with biomedicine, have chronic pain, or culturally want to have a different style of healthcare, are increasingly using complementary and alternative medicines. So that's a classification of the different kinds, and their sort of, the kind of therapies that they offer. So we've got different systems, we've got different kinds of intervention, we've got some that are biological based on herbs and dietary supplements, we've got some that are manipulative, and then we've got energy therapies for which really there isn't any scientific knowledge, scientific basis. So allied health, some allied health disciplines are regulated and registered, and so are some complementary and alternative medicines. And the argument there is that it allows the government to regulate their standards. Naturopathy is the largest group, and it's not a protected title. So anybody can call themselves a naturopath without having really any formal training at all. And the other occupations are self-regulating. So they're at the other end, so the other end of the spectrum. So you have medical dominance, you have allied health, nursing and midwifery, which are trying to carve out their own areas of expertise and autonomy, and you have the complementary and alternative medicines, which are relying on consumer demand, but also trying to chip away into that kind of health marketplace. So there's a lot of money spent on alternative medicines. So there's quite a big research area there, a lot of sociologists working on this. 4.1 billion. So we spend 170 billion on health as a whole, but 4.4 billion of that, and some of it is on vitamin supplements and things which can be argued not to be value for money. The most common ones are massage therapists and chiropractors. And in many cases, people are offering a style of therapy or a personal care that people don't find in the mainstream health system. next point that I want to make, which is an important one and connects with some of the things that we were talking about last week, is the gap between what's available in cities and what's available for rural and remote health. So this is just the AIHW summary of the inequalities. So people who live in rural and remote areas are much more likely to have chronic disease, the suicide rate is higher, they're much more likely to smoke, much more likely to be overweight or obese. They don't get enough exercise, which you might find surprising, really. There's an excess mortality of premature death and a lot of accidents. So in terms of social determinants of health and in terms of health provision, we have a big gap in Australia between urban areas where we've usually got very good health outcomes and rural and remote where we don't. And one of the elements of that is the access to healthcare. It can be people have to drive a long way to access medical assistance. It can cost them a lot of money to take time off work, to buy the petrol, to access any kind of medical care. And this is the number of medical practitioners per 100,000. So the other thing about our health system is that there is a huge imbalance between the cities and the country, but because medical practitioners are free to set up practice anywhere they like, the government is not able to direct where people where people practice medicine. They do try to have scholarships that are focused on rural areas, and we've got a medical school in a rural area. But it's something that you might think about when you're thinking about, where would your services be best used? Where could you actually contribute the most? It might be in a rural area, or even have an experience of working remotely. Of course, we may, with increased telecommunications, we are increasingly getting telemedicine, but there's a big role for particularly nurse practitioners, but allied health, kind of to be doing primary care in areas that are underserved. Another gap that's particularly relevant to healthcare, to mental health care, is the idea, at the other end of this kind of idea of a profession having a very, very high level of abstract knowledge and long period of training, is to actually employ support workers, people who whose qualifications are that they've experienced the condition that they're talking about. So I'm just going to show you a little film here about the role of peer workers in mental health.
Well, a peer worker could be something different in different organisations, but the essence of it is someone who has a lived experience of mental illness, who has an interest in working in the field and receives professional training in order to be able to make a contribution to others. And they bring their experience of recovery and their hope for recovery, and to share that with someone else. And there's no doubt, from what we've seen, peer worker can make a very real difference in someone's life. Because for someone experiencing a serious mental illness, hope can often be a very distant thing. And when they see someone else who's already had that recovery journey, who has the professional training to work with them, they can bring them a long way in terms of their own recovery.
A peer worker is a person who has been specifically employed because of their lived experience of mental illness, or because of their personal experience of supporting and caring for someone they love with a mental illness. And they're employed because of that experience to then share that experience and to assist other people in their recovery.
So knowledge that a peer worker has to do the job effectively is actually their experience of having gone through the issue, survived and recovered, and being able to show people the signpost to recovery themselves.
I'm working as a General Manager of Inclusion, and I'm also at Richmond PRA, and I'm also a Deputy Commissioner with the New South Wales Mental Health Commission. However, I still call myself a peer worker because it was a requirement of me to use my lived experience in these two roles, and that's what a peer worker is.
So we can work to advocate for people or help them to advocate for themselves. We can just be there as peer support workers, walking side by side with them, assisting them when they need to, talking to them when they need to, showing them pathways.
Into the future, I'm hopeful that peer workers will be able to fulfil roles at all levels within organisations. We need peer workers to be the bridges between services, to walk alongside the consumer as they navigate the varied maze of services. We also need peer workers at board levels, at executive levels, at policy and decision-making levels. And that is going to be the challenge that we confront into the future, but it's one that I think we're prepared to face now that we have a growing and rich evidence base around the benefits of a peer workforce.
I think that the main challenges to an organisation hiring a peer workforce really is discrimination. Fear. Discrimination comes because of fear. There's been so much fear around what will these people do once they're in our workforce. You know, you won't be able to trust them. They won't work professionally. They'll go off sick all the time. Well, that's just not true, you know, and certainly some of us do need to take some time off work sometimes, but so do people without mental health issues.
The business of being an employer is challenging. It's not easy. So whatever workforce you have, you need to be sophisticated in your approach to the needs of that workforce. So that, you know, when we employ peer workers, the issues are not necessarily any more than they are for the rest of the workforce, but you need to go into it with your eyes open. You need to understand you're engaging somebody who has a lived experience of mental illness, who's had training to work in the space, and that they may from time to time experience periods of unwellness.
The best way for organisations to overcome those challenges is by addressing workplace culture, and that's done through education, and that needs to happen at all levels of the organisation. So it's very important that senior management, like right at the very top of the organisation, understands the value of the peer role, where it comes from, and can articulate the value of the role, the benefits to the consumers, and so on and so forth. That needs to then be communicated to all levels of the organisation.
Okay, so I just want to finish by summing up pulling together some of these threads that we've got. Okay, so what we know is that we've had a very biomedically dominated system. It's very dominated by acute care, and the downside to that is that it doesn't address chronic illness very well because of the system being fragmented across different levels and between Medicare and so forth. We know that there's a demand because this demand for complementary and alternative medicine indicates that there's a demand out there for sort of more holistic, non-biomedical care. And we've also got the entry of occupations like the ones you're training for, other than medicine, into the kind of health arena. So we've got a very kind of rich tapestry there of different occupations, different levels of training and expertise, and we've also got demand by consumers to be included, which is where that idea of having peer support workers and peer mentors comes in. So if we think about the social model of health, what we're inviting you to do is to think about what could the health system look like if it was reoriented to deliver upstream care. So instead of it being a sort of pyramidal, acutely based biomedical system, if it was actually, as Nairi Brown was talking about with the Aboriginal medical system, if it was more community based, if it was multidisciplinary, so it was easier for people to access multidisciplinary care and for consumers and peer support workers to be really integrated. Yeah, I was just talking about this, and the fact that I showed you that NDIS example. I mean, one of the things that the NDIS has had trouble with is actually accepting that people who have intermittent mental health problems are actually qualify for NDIS support, because under the NDIS sort of is set up on the basis of a sort of biomedical idea that someone has a disability that's lifelong, and a mental health disability may be intermittent. So that's an important area where kind of peer support and the acknowledgement that of the value of people's experience could be really important. So what might the work of health professionals look like? So it might be, as I said, I'm sure that you're all focused on getting clinical skills, getting your qualifications. You want to graduate and get some experience, but we've put this segment in for you to think about what would be the directions of your profession to address inequalities, to employ the social model of health rather than just seeing things in biomedical terms, and to particularly bear in mind the issue of social inequality. Does anybody have any questions or comments that they'd like to make? Because I've basically come to the end of what I have to say. Thank you very much for coming in person. It's always nice to have real people to lecture to. And good luck with the rest of your studies. And yep, don't forget your sociology. So it's an acquired taste, but some people acquire it. Okay, well, thanks very much, everybody. Yep, I'm done.
Great, I'm on my way. I'll see you soon. Bye.
Okay. Thanks. Thanks a lot. Oh, good. I'm glad you found it interesting. Good.
Ended up being a few in the end.
Yeah, there was a scattering, about 10, 15 maybe.
Yeah, that's
Yeah,
right.
no, that's all good.
Perfect.
No, the second half went quicker than I was expecting. So
Great, that's no problem.
here we go. Just
Pretty much nearly time I knew I was about to walk down when you called, so that's good.
good. Okay, so. That's just that,
Yeah,
isn't
that's
it?
that one. Try and edit it this afternoon.
Yeah.
Takes a while to
Take
upload. I
out
usually.
some of my crummy transitions.
I know.
Sorry.
It's fine.
I think what confuses me is that it says low battery,
Yeah.
and I think it must flash when the battery's very low.
Ah, did that one flash?
No.
Oh, there
I
you
think
go.
it's fine. It was only down to 1 bar.
Oh,
It's down
but
to
it
1
wasn't
bar
flashing.
now, but it
Yeah.
wasn't flashing. But it always freaks me out. 'Cause
Yeah.
It says low battery, and then you've got a little red light, but it looks like you've got a low battery.
Oh, right. Yeah, get you.
Anyway,
Yeah.
all good.
Yeah, because they always say, "Oh, make sure it's got 3 bars." I'm like, yeah, there's such a waste of batteries all the time
I
too.
know.
You know, so I'm like, oh, if it's got 2 bars, I think it's still okay. And then
Yeah, no, well, obviously that was 2 hours and it went down
it
one
went
bar,
okay.
so
Yeah,
that's
so it's
obviously
probably right
fine.
to get changed now.
Yeah, no, I'm sorry the links weren't very smooth, so it's a bit clunky.
Oh, it's fine because what I do is any of the videos I just put the
You
link
just
in.
put
I
the
don't.
link in?
Yeah, because we're
Yeah.
not supposed to
No.
show them within the thing, so I cut that bit out anyway. So yeah, no, they work out pretty good. Kate's I think worked out pretty nicely. Like,
Good.
Yeah, it's about 15 little videos all up.
Right.
Just little
Oh, right, so
sections.
it's in little bits.
Yeah, little chunks. Yeah.
Okay.
Yeah.
Okay, so they're putting their sociology short answer, their sociology answer in on the 14th, is that right?
Yes, the 14th of October.
So
Yep.
I've got Kate and I are not marking that.
No.
We've got,
Other markers.
but we've got loads of markers who teach this material
great.
to nursing.
Yep.
So they know the stuff.
Yeah, I've got four marking for me because they're doing about 80 each.
I know, because it's such a big
it's
table.
huge. And sort of just at the moment, we're still just trying to get the marking right. You know,
Yeah,
just
I
making
know,
sure that
we'll have a
everybody's on the
meeting
yeah.
And, you know, we'll
Yep.
test mark
Yes.
across. and
Yeah.
do all that.
Because
yeah.
I
Yeah, 'cause
said, oh, it doesn't.
otherwise
I don't mind too much if the marks differ within the thing, but it's like once they start going from D to HD,
Yeah,
then
that's-
that becomes an issue. So
Yeah.
yeah, make sure that's all sorted. But yeah, that's great.